Technology Advisor and CIO Mentor for the National Health System of the Cayman Islands. And he's actually spent some time there living on the Cayman Islands. He's here in the U.S. now, but you know that we heard a little bit about that adventure, and you know it sounded glorious actually. He's also Senior Vice President at Healthcare Quality Catalyst in Salt Lake City and Senior Research Fellow for the Advisory Board Company in Washington, D.C. From 2005 to 2009, he was the CIO for Northwestern University Medical Faculty Foundation, associated with Northwestern Memorial Hospital and the Feinberg School of Medicine in Chicago. From 1997 to 2005, he was the Regional Director of Medical Informatics for Intermountain Healthcare, the healthcare's largest care delivery area, Salt Lake City, and Chief Architect for the Enterprise Data Warehouse. From 89 to 97, he held several IT leadership and consulting positions for a variety of organizations, including VP of IT Information Technology International, the U.S. National Security Agency, that's right, the NSA, TRW, Intel, and IBM. And then here, this is my favorite part. We're coming to my favorite parts now. So from 83 to 89, he served as a captain and one of 14 CIOs selected to fly aboard National Nuclear Emergency Airborne Command Posts. And, this is the best one, in 1988, he hacked into the National Nuclear Warning System from a public payphone. You deserve a round of applause.
Yeah.
Dale has a bachelor's degree in chemistry with a minor in biology and a master's equivalent in information systems engineering from the U.S. Air Force. And he's the founder of the Healthcare Data Warehousing Association, HDWA. If you guys don't know about that association, you know, Google it or look it up on the internet. It's very cool. That association is now comprised of over 200 healthcare organizations across the world. So with no further ado,
Thank you.
I give you Dale San.
Thank you, Lisa. Thank you, dear. Very nice. I forgot that did I tell you about that? I forgot I told you about the hacking thing. Yeah, that was, it wasn't very funny at the time to a lot of people, but it proved a point, and it's been pretty humorous ever since. A little more on that story. That happened over a few beers at a place called Gilmore's Lake Tavern in Omaha, Nebraska. And I'd been warning a lot of people. I said, I think I figured out how to hack into, it was called the Jsan. I said, I think I figured out how to hack into the Jsan from a public payphone. And one beer led to another, and we did it. But anyway, it was a lot of fun. Well, thanks everyone. It's really nice to be here, and thanks, you know, to Charles, and thanks to Sam, and thanks to Lisa for organizing this event. It's always very humbling to be invited to these things. I always kind of wonder why in the world would anybody want to hear me talk about anything. So I'll try not to waste your time today. It's very much an honor for me to be here. So you already heard all the bio. I think I might spend a little bit more time on this story. I told Dana about it last night, and she said it was interesting, so she's created a monster now. You know, now that I think I have an interesting story to tell, I'll be retelling it. I was working for the Pentagon. After I got out of the Air Force, I worked, well, let me back up even further. So I was in this nuclear warfare business in the Air Force. And I noticed a lot of variability in the decision-making around how to react in a nuclear warfare scenario. And it was very time-critical, very, of course, life-critical, highly variable decision-making environment. And so when I left the Air Force, I took this notion of trying to remove that variability and all of the bad consequences that that variability might have to the Pentagon. And I proposed that we research this and we try to computerize that decision-making. And it turns out there's these nuclear scenarios in which the president only has about 4 minutes to make a decision. And if you make a decision that's too early, you start nuclear Armageddon for no good reason, if there is a good reason. And if you wait, then you don't have the ability to respond. So you got 4 minutes to make this very time-critical decision. And so I went to the Pentagon and I said, let's study this and let's see if we can apply some advanced decision support to that process. And so I started doing all my research and looking at all the different ways that computers were used in time-critical, life-critical situations. And I thought, you know, I'm sure healthcare has nailed this. I'm going to learn a lot from healthcare. And so I came across these papers written by folks named Homer Warner and Reed Gardner and Al Pryor and Peter Haug. And I don't know if any of those names are familiar to you, but they're pretty famous medical informatics folks from Intermountain Healthcare, Scott Evans. And so I took a visit to Intermountain Healthcare to learn about how they were using these complex decision aids in decision making. And I was impressed. I mean, I was impressed. But I was also sort of surprised that if that was the best that healthcare had to offer, then there were going to be a lot of opportunities to do better things with computers in healthcare. So I literally came back from that trip, talked to my boss that was working for a company called TRW at the time, and I said, I want to get out of nuclear weapons and into healthcare. And so we started a healthcare line of business. We did some work all over the country. We sold it off to SAIC and did very well. But I didn't feel like I could learn healthcare until I became a part of it. So I went back to Intermountain and I said, would you guys hire me? And Diana and I worked together at Intermountain Healthcare as a consequence. So that was kind of the weird step that I made to get into healthcare, and it's been a lot of fun ever since. I might mention one more thing too. As odd as it sounds, I mean, the decision-making environment in the military is very similar to what it is in healthcare. You're trying to diagnose a problem. You're trying to manage false positives and false negatives. That's a big part of what the military is all about. Managing false positives and false negatives, diagnosing a problem. Someone mentioned this morning situational awareness. I think it was Ben. Situational awareness that's what the military is all about. And if you went into a command center where they're trying to make ICU type decisions in the military, they have walls about the command center in the National Military Command Center in the Pentagon is probably 7 or 8 times that size, with screens that are about 3 times the size of that. And that's situational awareness from them. And they're looking at everything from the availability of logistics in some Army base, Fort Carson, Colorado, to what's going on in the battlefield at a very tactical level. And that's how they manage that space of information. They don't do it on one monitor. They're doing it on very big monitors. So your talk this morning, Ben, was very interesting to me because I never really thought about the constraints that 15-inch monitor places on the environment, but it's common sense when you think about it. So I wanted to round out my career. I'm kind of a non-planner planner. I did the integrated delivery system thing at Intermountain. I did the academic medical center thing at Northwestern. I was actually headed to Canada to learn from a national healthcare system because I could see what was coming in the U.S. There's something coming in the U.S. that's going to look like a national healthcare system, I thought. So I was headed to Canada, but at the last minute I had this opportunity in the Cayman Islands. And everyone thinks I went to the Cayman Islands because of the surf and turf and all that, but I'm a mountain guy. I'm not much of an ocean guy, as it turns out. But it was still awesome. I went to the Cayman Islands because it was a national healthcare system at a manageable size. So I've had the incredible fortune to work on everything from public policy and tort reform down to configuring web browsers for physicians. And it's been a life-changing experience for me. It's been awesome. So the Cayman Islands, and I'll share a little bit more about some of the cool things that we've done in the Cayman Islands in this kind of working laboratory. Just, again, so everyone knows I have these 3 affiliations. There's nothing really more than that to know about it. The healthcare quality catalyst thing is we're trying to commercialize the data warehousing and analytic technology that we developed originally at Intermountain. And then we've been refining ever since. We've built a version of it at Northwestern, went very well. Another version at Alina. So we're trying to make that more readily available in the market. So you'll see that influence in a lot of what I talk about. I'm kind of a data warehousing guy. The advisory board, I'm just an advisor to them on usually BI related, sometimes EMR related things. And all the money that I get for that goes to Habitat for Humanity, so there's no conflict there. I occasionally overcharge them for that, so it's a good way to get a little more money. So this is a picture of right out my back door. I'm enormously grateful. Life has brought me back to Durango, Colorado as my hometown. So I still work for the Cayman Islands. I still travel down there, but I'm now able to work from Durango, which is my hometown, spend time with my mom, who's 88 years old. I show this picture just because it's beautiful and I love it and I'm grateful to be there. But there's also something about being raised in the mountains. I mean, literally, this is my backyard. This is where I grew up, on horses and foot in these mountains. And there's something about being raised in the mountains. Some people would say it makes you odd because you spend so much time alone. I prefer to think of it as colorful. But at the end of the day, I think what it creates in those of us who grew up there is a sense of independence. And if you can't, those of us who grew up there tend to ask why a lot. And if you can't give us good answers to why, we're probably not going to be around for very long. We're probably going to seek company otherwise. So maybe you'll see some of that in here. And I don't mean that to sound self-righteous. It's just I'm trying to explain my peculiarities. So let's talk a little bit about what I'm calling healthcare 2.0, right? And which is, I think we're all in the middle of that by one name or another. We'll talk about what we've done to revolutionize the revenue cycle in the Cayman Islands. So I never really worked around the revenue cycle too much in healthcare until the Cayman Islands came along. And it's been awesome, and I'll share a little bit more about what we did. I'll talk a little bit about 5th generation EMR, so all the discussion and everything that Ben brought up, and where did Jim go? Jim talked about suggestive. Did you see? I have a copyright on that, Jim. Did you see that? Suggestive analytics. So that's somewhat tongue-in-cheek. I'm teasing, but I really do think there is room intellectually and in the market for this term, suggestive analytics. And I don't know if I'm the first one that I started talking to about it. I don't know if somebody else did, but there's room for that, and I'll talk a little bit more about what that means. And then I'll talk a little bit about Watson and big data and sort of my predictions about that. And that'll be it. So did everybody see? I'm surprised nobody saw that or talked about these headlines today about Toyota putting out a bid to buy Kaiser. Did anybody see that? Nobody saw that? Wow. So anyway, employers are taking over. Toyota's put a bid out to buy Kaiser Permanente because they're basically tired of putting up with the status quo. So that's going to be very interesting. Of course, it's not true. Has anybody heard me tell this joke before? It's not true, but I don't think it's that far from being true, and it's kind of believable if you think about it. Employers are not going to tolerate the current state of healthcare for much longer. So whatever is happening with the Affordable Care Act and the Supreme Court decision about the individual mandate, I think the genie's out of the bottle, and there is no turning back from what we're calling, or what I'm calling, healthcare 2.0 anymore. So the reality is, employers are starting to take over. This is a quote from Paul Grundy. He's the medical director for all of IBM. Very cool guy, very disruptive, very cantankerous. And this is what he said in a recent meeting. He said, "We know the healthcare systems that provide the best care and control their costs. We know which ones can show us their data that proves they manage quality and cost. And we know where those healthcare systems operate geographically. Guess what criteria we consider most important now when making a decision to open a new plant or office?" That's awesome, isn't it? I mean, I love that. That's the kind of disruptive attitude we need to have from employers to drive the difference that we need in healthcare. And if I'm the mayor of a city, I'm going to start listening to this, and I'm going to start investing in better healthcare to attract employers in my town. Right? It's very interesting. So I won't, rehash this. You guys know all this. Healthcare 1.0 is the fee-for-service model. It's encounter-based. data collection and analysis environment was primarily driven by billing. I mean, if you look at the way EMRs have evolved, Ben, they really evolved more as a way to address malpractice and billing. It wasn't about physician efficiency. It wasn't about patient quality of care. It was about billing and malpractice. We're moving into fee-for-quality project-based healthcare. So we're moving away from just the encounter to the project, the start-to-finish project of delivering care to a patient and eventually health, right? And the data collection and analysis environment needs to be driven by quality, efficiency, and affordability. Okay? So quality of care is important, but quality of health is even more important. So we're going to move from quality of care, the delivery of care, to quality of health. And the truth is, I don't want any health care. I don't want a clinic visit. I don't want a hospital visit. I don't want any health care. So I want a healthcare system that supports me maintaining my health outside of the walls of the organization. The only time I want to be in a healthcare setting is if I have an accident on a skiing or mountain biking or a horse or something. Okay? So please keep me off of your disease registries and out of your facilities. So the heart of the analytics equation in Healthcare 2.0 is reminiscent of other industries that have been dealing with this for many, many years. Right? So it comes down to the quality of the product you produce divided by the cost of producing that product plus some margin. I mean, this is what every other organization, every other business in the world, this is what drives their value statement completely. It's the quality of the product they produce divided by the cost of production. And what you're always trying to do, of course, is drive the denominator down and the numerator up, right? And at best, what we do in healthcare is the CMO tries to manage quality of health, and the CFO sort of manages cost of production, but they're really managing cost of operations. And that's a different thing than cost of production, right? They're managing cost of operations. So in the right system, you'd make a little bit of margin, you'd feed that back into dividends to employers and patients and return some of that. Right? And again, I just want to emphasize that the cost of production concept does not equal the cost of operations. And that's the mindset that we're in right now. We're still dealing with cost of operations. We don't know what it costs to produce a good outcome. We don't know what it costs to produce a healthy person or a great surgery. What we know is how much it costs to do something, but we don't know what it costs to produce. And I would suggest that the CFOs in healthcare, we're all talking to the CIOs. CIOs, we have a terrible job. We've always had a terrible job. We have to evangelize products that are terrible. But but the CFOs in Healthcare 2.0, I think, may be the folks who have the hardest time adjusting, because they've been dealing with some version of the denominator. But now they've got to start worrying about the numerator and the denominator together. And I think that the CFOs in Healthcare 2.0 are going to have a really hard time adjusting to that. So I just might suggest that going back to this Healthcare 2.0 environment, Healthcare 1.0 was kind of about data collection and the adoption of EMRs. Then came data sharing and the adoption of HIEs. And now we're entering into stage 3, which is data analysis phase. And for the most part, that's characterized by some version of a data warehouse. Okay? This is a great guy. If you ever get a chance to watch any of his videos, Eric Bryn Jolson from MIT, very cool guy. I mean, he's very intellectual, but he's also very pragmatic. And I'll read this off. There are a lot of companies who think they're using data, but historically that sort of data has been used to confirm and support decisions that had already been made by management, rather than learn new things and discover what the right answer is. The cultural change is for managers to be willing to say, that's an interesting problem, that's an interesting question. Let's set up an analysis to understand it, let's set up an experiment, show some vulnerability, and say we are open to the data. So the message there is that analytic value in Healthcare 2.0 isn't just about technology. It's about adopting a data-driven mindset and the processes associated with turning that technology into something useful. And if we all thought that the workflow changes and the cultural upheaval associated with EMRs was tough, analytics is even tougher. Because as Eric mentions, you have to peel away your ego to face the truth that data can reveal sometimes, and that's not comfortable to do. And going back to Intermountain, that's still one of the most amazing things about Intermountain Healthcare, is how selfless they can be about the analysis of their data. They've kind of fallen off of the informatics roadmap a little bit because of their struggles to convert from help to a more modern platform. But there's still no healthcare organization that I know of that is as selfless and as reflective about data analysis as Intermountain Healthcare. And they've really nailed both sides of this equation. So this is a complicated diagram. Sorry, guys, it's a bit of an eye chart for those in the back. But what it shows is kind of the ecosystem of healthcare. From collective consumption and prevention epidemiology on the left side to governance and health system administration at the national, federal, and local level. Here in the middle, it shows the natural history and progression of disease from low risk, then you're at risk, early signs and symptoms, progression to disease, then some form of disability, decline, dependency for self-care, and then eventually death. It's kind of interesting, isn't it? Yeah, thanks, Will. Yeah, there we go. There's our life right there. There's no escaping it. We should put a brighter version of this up, shouldn't we? They're all going down, yeah. Well, maybe we should, down at the bottom here, we should say, like, Nirvana or something. So it's not all bad. Yeah, closure, that's right. What I'm going to try to do is overlay kind of the analytic environment. So if everybody saw that one pop up there, we're kind of consumed right now with measuring chronic diseases. That's about the best that we're doing right now with data in healthcare. We're kind of measuring utilization of chronic diseases. Well, that's okay. Every once in a while, we do a pretty good job with epidemiology and sort of public surveillance, right? It's number two, but we could get better at that. But 1 and 2, we're doing reasonably well right now. This is an area where now we're kind of making the divide between healthcare 1.0 and 2.0. Now, number 3, that personal prevention and being proactive and using our analytics to inform better decisions at the personal level is where we need to start moving, all right? We're going to face a situation soon, we already are, where long-term palliative care is very important, and we have to be better informed about the analytics in that arena. I see almost no quality improvement analytics around palliative care at all. And I try to watch all of the journals and things for this, but I don't see much of anything being produced about improving palliative care, end-of-life care from an analytics perspective, from an outcomes perspective. And I know it's hard to define outcomes in that setting, but I think there's room for research in that area that we're overlooking. Absolutely we have to get to cure, treatment, and rehabilitation more effectively. And then finally, we'll get up into the area where we're proactively keeping people off of disease registries at those early signs of at-risk conditions. And then finally, that will hopefully inform a better governance structure and funding model. So all this talk about analytics, and I was glad that our panel put this slide up. I believe that we need to have a more formal approach to understanding how analytically capable we are. And HIMSS put together the EMR adoption model. My friends and colleagues at the advisory board, formerly at HIMSS, were a part of that. It's not perfect, but it worked, and it helps. And it's progressed the industry, and it's helped vendors, and it's helped organizations as well. So I'm struggling to find a way that we apply those same concepts to analytics, because I think it's as big a problem, if not bigger, than the adoption of EMRs. So there are 2 draft models that I've been working on in collaboration with some of my friends, Tom Burton in particular. And so this is the first public reviewing with all of you guys today. This is like some kind of coming out party. So just for a refresher, there's the EMR adoption model, stages 0 through 7. And it's kind of interesting in that at the top level is the adoption of data warehousing and analytics, right? So we kind of build on that, assuming that there's an EMR. So this is version 1 of that analytic capability maturity model. And by the way, I would love for feedback whenever about how to make this better and more useful for the industry. So at the lowest level, we have stage 0, which is characterized by spreadsheets and desktop databases. Stage 1, you're able to put together basic compliance and regulatory metrics and analytics, SOX, EMTALA, state registries, and that kind of thing. Above that is accreditation, Joint Commission, HIMSS, NCQA. Professional societies, STS, NERMI, Vermont, Oxford. So if you think about this, those of you who are in a healthcare delivery organization, just kind of mentally pause and think about how are you addressing each of these different stages? And I bet most of you are doing what most of us are doing, and that is there are little point solutions kind of spread all over the organization. It's costly to maintain, it spreads out resources, both financial and people. And it's also, you see overlap between these, so you get competing versions of the same answer and different versions of the truth. Above stage 3 is patient or payer financial incentives like PQRS, meaningful use, and that kind of thing. Translational research is next. Quality, cost, and let me just back up and say that I think a lot of organizations, and probably UC Irvine is one of those, probably figure out a way to get up to stage 5. In some fashion. It may not be efficient, it may not be all that cost effective, but somehow or another you're figuring out how to get through stage 5. Stage 6 and 7 are those healthcare 2.0 areas where you're really starting to get this trade-off between cost and quality. You're really starting to understand that equation. The quality of your product divided by the cost of production. And you're finding the optimum for that, right? Where you drive the denominator down and the numerator up. And again, Intermountain is one of those organizations that's managed to do this. Kaiser is pretty good at doing this. And then finally, stage 7 is the preventive and predictive. So now you're working on capitated payments, and your reimbursement model is based on wellness, not necessarily on healthcare delivery, but on wellness delivery. Okay, so there's one model. Here's another model. It's a little more wordy, and I don't know that I'll go into all the details here, but let's start at level 0 to give you a feel for what's going on. So at level 0, this model assumes that you have a data warehouse in place, or that you're inclined to build a data warehouse. And I'm not so sure that that always holds up, but let's assume that it does for this example. So the major data sources are all located in a single repository. So you've got at least EMR level 3 data, revenue cycle data, financial data, costing data, supply chain, and patient experience data all in one repository. So you have a pretty robust library of content. So now you can understand the kind of care you're delivering, the cost of care you're delivering, and what the patient's perception of that care was. All right, so you've got the basic library in place. Then you've got a vocabulary and a metadata repository that allows you to search that content and allows you to map different sources to the same concepts. You've managed in level 2 to automate your accreditation and regulatory reporting. So you can start to see some overlaps between these two models. Next, you've moved up and you've automated in level 3 the PQRS, meaningful use, and the quality measures for external reporting that Dana talked about. Level 4, evidence-based analytics. So patient registries now are defined by evidence for at least the top 10 conditions in the organization. And what I mean by, and this gets back to what Dana was talking about earlier too, I've moved right now, I've been in Intermountain, I've been in Northwestern, I've been in the Cayman Islands. All 3 of those organizations define a diabetic differently, a hypertensive patient differently, an asthma patient differently, a myocardial infarction patient. Every one of those have a different definition for those disease states. If we don't come together as an industry and define what we mean by those disease states from a discrete perspective, we'll never be able to benchmark. We'll never be able to understand this. So we're working with the British Medical Journal right now to scour the best evidence that they have across all their international journals, including those in the U.S., to define how you define these disease registries. And we really think that's a very important part in reducing variability, not at just at the local level, but at the national level as well. At level 5, you've got broad analytic deployment. So we're saying that to reach that level, 80% of your employees have to have data pushed out to them that's relevant to their job function. Then you're starting to get into waste identification, and personalized patient analytics at level 6 and 7. That starts to get pretty complicated. I'll make a quick comment on level 7. At level 7, we're starting to integrate genomic, familial, and patient-reported data, and we're blending that into a predictive model. And it's about preventive care and wellness management at that level. Okay, so I kind of like this model because it gives you a roadmap and something to stretch for, and it's somewhat measurable. The other is also it's a good framework and it's simple, but if you get a chance, I would love for everyone's feedback on how to adopt this. I'm working with HIMSS and class and the advisory board, and I'm not sure exactly who's going to own this at the end of the day, but I would kind of prefer it to be HIMSS, just for sake of consistency, but we'll see. Okay, so let's talk about the Cayman Islands system for just a second. Most of my time in healthcare has been centered on clinical decision support, making EMRs better, and that kind of thing for the physicians and nurses. When I came into the Cayman Islands, they'd been operating in the red for all 14 years of the organization's history. And so just for lack of money, I mean, we kind of had to do something. No money, no health care, right? We were running out. So I dove into the revenue cycle like I've never been involved before, and it was fascinating. At the end of the day, we found about $48 million in unbilled claims because the way Cerner was configured. So it was easy to turn around, right? The red line went from below, I think we lost $7 million the year before, to $2 million profit. So there's somewhere around a $10 million swing in 1 year just by changing a few things in the revenue cycle system. But it was interesting for me because I'm a big believer in changing the economic model of healthcare. So to give you some idea of the Cayman Islands, it's 3 islands. I would just point out that we are not here. But that's where it is. It's a little south of Cuba and a little bit north of Jamaica. 3 islands, 50,000 people. It's a territory of the United Kingdom. It's been tax-free since 1794. So it's not like it just emerged as this tax-free haven, in some sort of corrupt conspiracy. I don't know if anybody knows the story, but there was this wreck of the 10 sails where 10 British merchant ships piled on top of each other outside on the reef of the Cayman Islands. And the people of the Cayman Islands went out to help recover and save people. And King George rewarded them for that by granting them tax-free status. And in 1794, for the United Kingdom and the King George to grant anybody tax-free status, that was a big deal. So they really hung on to that as a part of their culture. And it's been fascinating for me to see a government operate without an income tax. They basically use a national sales tax. And so it's very, very interesting. My paycheck from the Cayman Islands had 1 line on it. Yeah, very cool. It wasn't very big. It was a tiny little line. I didn't make a whole lot of money while I was down there, but it was very cool though. It was very cool. One of the things that's very cool too is there are 128 different races and nationalities in that 50,000 people. So it's fascinating. It's not unusual for me to be around a table with 8 people and there'd be 7 different dialects or languages or versions of English. So it's very cool. $1.7 trillion in financial assets under management. So it's number 5 in the world. I give you just a little more background. Part of my background, I worked for the National Security Agency. And I worked in counterterrorism and counter-espionage around nuclear weapon systems. So after the Soviet Union collapsed, there were a lot of organizations racing around to get into the former Soviet bloc and steal those weapon systems because the Soviet army basically walked away from them. They weren't getting paid anymore. There was no command structure. They went back home to Moscow and every place else and left these weapon systems all unprotected. So anyway, long story short, there was a team put together and we tried to intervene and stop all of these things. And then that led to kind of a trail of investigation into how these terrorist organizations operate. And this was in the early 1990s. It was right after the Soviet Union collapsed. And it's fascinating to watch the sophistication of the financial laundering process that terrorist groups have progressed, because we just caught a glimpse of it in the early 90s. And as it turns out, they were stashing a lot of their money in the Cayman Islands. The funny thing is, we came across this, but we also came across these secret bank accounts that the NSA and the CIA kept to pay off all of our bad guys that were informing us. So, you know, we're trying to reveal and make this more transparent. At the same time, we're being told, no, don't you dare. So, it was interesting. So I had a picture from Durango in Colorado. So this is a picture literally outside my door in the Cayman Islands. Isn't that crazy? I mean, I mean, every time, I can't even tell you how many sunsets I went out and watched, and I just never got tired of it. It was so cool. Great place to be. So, one of the nice things about the Cayman Islands is they have a lot of great restaurants. And the other thing that was kind of cool is that they have a lot of economists and financial guys there. So you can talk economic models and that sort of thing to them, and they're all about money. They're all about sustainable economics and that kind of thing. So I'll go through this and tie those two stories together. So imagine if, you know, healthcare managed a restaurant. You'd wait 45 minutes for a table, even though you had a reservation. And by the way, this is all tongue-in-cheek, guys, right? Don't anybody get offended. You would tell the waiter that you're hungry, but there's no menu. Interesting. The waiter would return with a meal that he thinks is appropriate for you, but he doesn't know how much it costs. You would have no idea what the food is or what it costs, but you agree to eat it. You leave without knowing your bill. Interesting. The restaurant sends the bill to your bank, not you. Your bank would tell the restaurant, your waiter ordered the wrong thing for you, we're not paying for it. 90 days later, the restaurant would call to tell you that your account is being turned over to collections. There's a funny story too. Lyle Berkowitz, a dear friend of mine and my primary care physician at Northwestern. When I was going to the Cayman Islands, you have to get a physical to get in the door of the Cayman Islands. Make sure you're not carrying any communicable diseases and things. So I went to Lyle, and Lyle had to give me a physical, and part of the physical required a chest x-ray. And so he ordered a chest x-ray. I literally walked out of his office door next door. And remember, I worked at Northwestern at the time. I walked in the door next to it, got my chest film, and everything was good. He sent the report to the Cayman Islands. I got into the Cayman Islands, okay. Clean bill of health. And I get a call from a collections agency when I'm in the Cayman Islands that I haven't paid my bill at Northwestern for the chest x-ray. And I said, well, I didn't order the chest x-ray. Lyle ordered the chest x-ray. I don't have to pay for that. Oh, no, you have to pay for it. So long story short is I had to raise it all the way to the CFO, to Pete McKenna, to say, Pete, this is crazy. You can't turn me over to collections because of this chest film. Lyle ordered it. I didn't know what was going on. Anyway, it was funny to be stuck in the middle of all that. So the Cayman Islands healthcare environment is it's small. It's like a rural healthcare system in the U.S., only it's even more isolated. So you have all of the challenges of managing a public health system, but you have very limited financial and human resources to do so. And so for a person that loves exploring and adventure, it was very fun in that regard. It's trying to figure out how to run a full Cerner shop on a tiny little rock in the middle of the ocean. And one of the things that I'd like to emphasize here too is that, and this is what I learned from Intermountain. There's nothing like an organizational structure to clarify accountability. And the major thing that I learned at Intermountain is that if you have an insurance arm and a healthcare delivery arm under the same CEO, that CEO is going to manage the economics of care and the quality of care with a different mindset. I think it ought to be a law that every healthcare delivery organization in the U.S. ought to have an insurance arm as a part of the organization. because it would force a different mindset on the governance of the organization, and it would disintermediate the big waste that the insurance companies place on the system as well. So I'd like to figure out some way to introduce that risk management process under every hospital CEO in the country. I think it would change the game in a big way. So you can think of the national insurance company Cineco as equivalent to the CMS. Basically, that's what it is. They cover about 70% of the lives on the island. The other 30% have a private option. I'll talk a little bit more about that. One of the interesting things is it's almost 100% CPT driven, hardly any ICD driven reimbursement. And it has some pros and cons, but we're moving towards capitation, both inpatient and outpatient on an ICD basis. And again, the cool thing about it is these folks have a culture that's willing to change things. They have a culture and a willingness to change down there that I really appreciate being associated with. So think of them as a government-private hybrid. The government owns 2 hospitals and clinics, and they own an insurance company. And in the U.S., the analogy that I like to draw is imagine that the VA and DoD hospitals now accepted civilian patients. And Medicare sells a very basic, affordable health care plan. That's basically the model that they have there. They have a government-owned healthcare delivery arm, and they have a very affordable insurance arm. You can buy private insurance, and you can go to private hospitals. In fact, there's a giant new hospital being developed down there by Dr. Debbie Shetty and Ascension Health. It'll be a 2,000-bed hospital in Medical City when it's done. But the government ensures that you have at least some access to care and affordable care. And private choice is accommodated. So I think it's a very cool model. And remember, they're doing all of this without the IRS. They have no income tax. And so all of the money that goes into managing and frittering your way on the IRS and taxes and like that, they take all of that and that level of inefficiency in their economy is gone. Now, it's a little painful when you go to the cash register because you pay tax. Everything feels like it costs a lot when you pay at the cash register. So there's this human dynamic that's a little weird to deal with, but that paycheck is very simple. So the economic mindset there is different. Revenue to our hospitals and clinics is an expense to the Ministry of Health. So we can't go in and talk to the ministry about how great our revenue cycle is doing. He doesn't want to hear that because that's an expense to him. And I say we, the board of directors there, we believe that the economic model in healthcare is as much to do with the poor quality of care as anything else. And we believe that if you change the economic incentives, quality will improve too. So, one of the things that we want to do to change the economic model is to make it look more like a retail transaction system. So this is a partnership, this CarePay project is a partnership between HSA and Cineco. And it's a real-time point-of-care eligibility verification and claim system. The goal is to model a retail and credit debit card transaction. The patient knows their coverage and their out-of-pocket expenses at the point of care, so there's no mystery billing, 60, 90 days later. There's no more claims, there's no more denials. And we've eliminated medical record coding from the billing process. So to give you some idea of what we're trying to attract, and again, why are we worried about this? It's the quality of the product you produce divided by the cost of production. And this is a major expense in the cost of production in healthcare. The overhead associated with claims processing and the exchange of information in healthcare is crazy expensive. So in the Health Services Authority in the Cayman Islands, 103 FTEs are involved in HSA billing and reimbursement. In the U.S., this amounts to 31% of all of our healthcare costs associated with the economic model. So what we're trying to do is drive that denominator down and apply some common sense to it. Going back to that restaurant analogy, we tolerate things in healthcare that we would never tolerate in the rest of our lives. That crazy analogy, that non sequitur of sorts in the restaurant, I don't know why we tolerate it in healthcare, but we do. So in the Cayman Islands, that amounts to about $50 million in savings per year that we can turn back into better salaries for employees, better facilities for patients, and better preventive care. So here's a flow chart of how this system works. A patient comes in, they swipe a card that identifies them. It goes out and immediately checks to see if they're eligible for care. We enter those folks and we bring up Cerner in the patient identification and arrival process. These two pieces are not integrated yet, but they will be. We fake a claim to check their balance before they go in for treatment, either inpatient or outpatient. We send in a fake claim. It returns a summary of their benefits and how that claim might balance. If we see a problem with that, if we see that they are headed in for treatment that they can't afford, we intervene right there with patient financial services and we set up a payment plan. If there's no problems, we just let them go on back and we treat the patient as we would normally. At the end, this is very interesting, and it gets back to how much time do you have for documentation. We purposely extended the clinic times to give physicians the time to finish their documentation at the point of care. So all of our average times now are out to 30 minutes. If it needs to go longer than that, we'll do that. But we want that documentation to be finished at the point of care. We think that's the best practice in general, but it's a required practice in this billing environment because they'll round out that documentation, they'll issue their orders. By the time the patient gets back up to the front desk, that documentation is done, plus or minus 5 minutes. The patient swipes their card. We pull an extract from Cerner, a clinical summary extract from Cerner, enough to adjudicate the claim. We ship that out to the PAS system, that's the claims adjudication system, and it completes the transaction. If there's a self-pay portion, it returns that. The patient pays the self-pay portion and everything is done. There's no claim associated with it. There's no denials. There's no coding department involved anymore. And I really think this is not a dream. I actually would love to come back to the U.S. and find a small, nimble healthcare organization in a rural setting that would work with a local insurance company and see if we can't do this here as well. I'm talking actually to some folks, and I don't have any commercial interest in this actually. I mean, my whole interest is just doing better things for the country. So it's not like I'm making money off of this. I just think it's a great idea. I'm working with a couple of states that want to do this around their state employees. So, okay, enough about the Cayman Islands. So let's talk a little bit about suggestive analytics and fifth generation EMRs. And again, thanks Jim for introducing that. So, there's a lot of hype and discussion going on right now about predictive analytics. And I think it's cool, but I'm not quite convinced it's going to do what we think it is. So my theory is, and this is a little over dramatic, but I think you'll get the point. Predicting healthcare comes in two flavors. It's either too easy or too hard. I mean predicting healthcare with a computer, okay? So this one's too easy, right? If you have a BMI of 29, you're a smoker, and you're sedentary, we know you're going to have multiple chronic diseases. If you're 65 years old, living alone, post-cabbage, we know you're highly likely to be readmitted. I don't need Watson to predict either one of those. All right? On the other extreme is it's too hard. And this is an example of a friend of mine. BMI of 21, active, probably 6% body fat, 39 years old, non-smoker, non-drinker, has a stroke. How do you figure that? There's no computer in the world that's going to predict that in our lifetime. BRCA1 and BRCA2 mutations. I had the great fortune of being associated with some of that work at University of Utah and Myriad Genetics. We know that if you have a BRCA1 and BRCA2 mutation that you're 60% more likely to have breast cancer. But we also know that we've got clear evidence about 150 other known genetic markers for risk that we basically ignore in healthcare right now. So there's some weird things going on with predictive analytics, and it's a big buzzword in IT, and it's a big buzzword with vendors, but I'm very skeptical about our ability to do anything with it. And part of that skepticism comes from my military days, and that is we had an unlimited budget to do text mining. I mean literally an unlimited budget to do text mining and try to predict what terrorists were going to do next. And we were still not good at it. And even when we were good at it, we were never quite sure enough to intervene. We're getting a little more bold in that capacity now in the military, but it's the cultural and operational and behavioral issues associated with intervention from predictions that are a bigger issue. So the problem is either too easy or too hard, but if we do manage it, and the BRAC 1, BRAC 2 is kind of an example of that, even if we do know about it, we have a hard time intervening, culturally and operationally. And this is a quote from a friend of mine who worked at NSA. And he said, "We knew the 9/11 scenario was a risk, and some airlines had already put storm doors on their cockpits to mitigate hijackers in general, but we just didn't push the mitigator hard enough." And I really think this philosophical issue about intervention based upon prediction is one that we're not dealing with healthcare at all right now. We just talk about it as if, oh yeah, all this data is going to give us all sorts of predictive ability. I don't know that we have the cultural or operational ability to do anything if we do know about it. So what I would suggest is that there's something easier about this, and I copyrighted this with tongue-in-cheek because I had no idea that Jim was going to mention suggestive analytics. A few years ago, I was out at a healthcare think tank conference at Cambridge, and I presented this EMR user interface that had patient care data, population management data, and cost of care data all in one user interface. And I called it the Healthcare Information Triad. And Don Berwick was in the audience. And a few weeks later, Don Berwick published his editorial about the triple aim. So I don't know who came up with it first, but I thought I would go ahead and copyright suggestive analytics while I could. So the notion is that we should surround our decision-making environment with suggestions based upon analytics. It's much easier than predictions. There's a book that's a great book. It's one of those airport books. You can read it like that. The nut of the message is if you give people exposure to data, they will generally adjust their behavior. That's kind of the nut of the issue that book summarizes. But it's got cool case studies. I really highly recommend everyone read that book. And so here's an example of suggestive analytics, right? At Amazon. We're surrounded by suggestions. So up above this is actually a screenshot from my Amazon page. I probably should have checked this first to make sure it didn't reveal some very interesting something about me. I literally have not looked at this. Interesting. Anyway, so yeah. Surprise! It is a surprise, isn't it? So look, but you can see, right? So what I think I was out looking at Nudge actually, as if I was going to purchase the book Nudge. But this is what Amazon suggested with their analytics. Other people bought these books, and here's the rating for it. And there are 96 of these used and new from $14. Right? So there's all this suggestive analytics that surrounds my individual transaction and influences my behavior. And I think it's a great way. I mean, Amazon's motive is to upsell, but I'm okay with that because I get some cool suggestions out of it. Right? And I think we're overlooking this opportunity. And by the way, kind of going back to Ben's comment earlier, genetics and everything, that was such a cool, I love that metaphor. The genetics thing and the whole Bible in the beginning thing killed me. That was awesome. One of the problems with that model in healthcare is EMR vendors are as incestuous as the British monarchy in the 12th century. There is no genetic variation going on at all among EMR vendors. That's the problem with that model. We need to introduce new thoughts and ideas. We need some genetic variation into the environment in a big way. In a big way. So, in addition to suggestive analytics, we can also borrow other ideas from Amazon. So this is my mock-up of what an order might look like in an EMR, borrowing ideas from Amazon. Right? So I won't go into all this, but you can see that when was the date or when was the item ordered, Over here, you could have quick references and costs. You'd have, if you wanted to, a picture of the pill, the procedure, the device, display filters. You'd have a summary of open orders with no results. Order history for this patient could come up easily. You'd have opportunities to reorder if you wanted to. And all I'm suggesting is I think there are opportunities for the EMR vendors to start borrowing thoughts and ideas somewhere else and increase the genetic, that hybrid vigor in the industry. So I did the same thing with Facebook. What if Facebook built an EMR? What would it look like? Right? So up here you'd have referrals, notifications, events, and messages. This is another one of those things I haven't looked too closely. I don't know what's on here, but up in this area, you'd have a patient summary with problem list. You'd have a photo. You could go into patient details in the info button, orders, results, and images here. Members of the care team listed over here, where you used to have friends, right? A running summary of events that's occurred around this patient, right? Clinical notes from the care team friends, patient comments, images, videos, results, graphs, a running history, and then over here, clinical recommendations. Something to think about. So let's give a more tangible example of suggestive analytics. This goes back to Intermountain, and Diana knows this very well. One of the cool things about the antibiotic assistant that gets a lot of attention at Intermountain is somewhat unappreciated. It gets a lot of attention because it's a complicated decision support tool. So Scott Evans, the PhD informaticist that Diana and I worked with, built this system with Dave Clausen years ago. And what it does is it takes all of the patient profile, age, gender, all the lab results, all the path results, et cetera, folds that all into this very complicated decision support matrix, looks at history of antibiotic protocols with similar kind of patients, and then it makes recommendations about the protocol. And it actually lists out usually 10 different options. So you've got option 1, and it tells you what dosage, the route, interval, and the predicted efficacy. It's very cool, right? So there's the predicted efficacy. That's a good use of predictive analytics. And they use that based upon outcomes of previous patients. All right? So if you're a physician, what are you going to do? You're going to pick the top option every time, right? You're going to pick the top option. Of course I am. I'm going to pick the top option every time. But what we noticed in the background is that sometimes the option was the top option was way more expensive than the second best option. So Scott didn't even tell anybody about this. We all just were talking about it one time, and Scott revealed this column. Didn't even tell anybody he was going to do it. Didn't have a big formal review, didn't have a big, blah, 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 change control process or anything. He just turned it on. And what do you think happened? Physicians immediately adjusted. And so, to me, when I saw this, I thought the decision support is cool, but what's really cool is they put options for treatment with cost of treatment in the same environment. And it changed everything about the way I looked at EMRs. So the results, complications declined 50%, average number of doses declined from 19 to 5.3, and the bigger story, I think, the cost per treated patient went from $123 to $52. And you didn't have to strangle a physician to do it. All you had to do was give them the data. Okay, very cool. So, 5th generation EMR. This is kind of a chronic disease management perspective. I loved Ben's layout. That was so cool. Laying that all out on a 30-inch screen was fascinating. This is more of a chronic condition management perspective. But what I tried to do is blend those pieces of information that I think we need to leverage more effectively. And a lot of this is driven by analytics. So in this area, you've got patient-specific information about Jane Doe. In this quadrant, you've got patients like Jane, right? So that you can drill down into an understanding of how patients like Jane are being treated and who was treating them in case you want to have professional dialogue. and also what was their outcome. You've got a summary of the orders and the treatment plan here, and there's a running cost, so you have an idea, and you can start talking to folks about what they can afford and what they can't afford, and you can tailor their care. And then here you've got Jane's patient management scorecard relative to her chronic conditions and the rest of the population management that share those chronic conditions. So you can see that from a traditional perspective, that, some EMRs like Cerner, and Cerner I will say in particular, they're doing okay with the chronic condition management reports. We're actually making progress with that quadrant. But no one is working in these quadrants. Patients like Jane, the kind of the social aspects of care, and no one's dealing with cost of care at the point of care. So we need to push the EMR vendors to start thinking differently. Okay, are we done? How much time do we have, guys? Are we over time? We're over time? Okay, we should stop. I'll blow through these really quickly. Watson, it's cool. It is the coolest thing in the world. Frankly, it's the first thing in IT that I've been excited about. But it's also, it's natural language processing really hasn't changed a whole lot. Google changed the game when they took natural language processing and parsing and semantic mapping, and what they do to it. They laid something over the top of it. They laid clickstream data as a meta layer over that NLP. And that's what that was the game changer, is that Google laid clickstream data over the top of their NLP to change the way that those hits were ranked. That's what changed the game. And that's what we need to do in healthcare. It's not enough for us to parse and map NLP anymore. We have to lay discrete data of another kind, contextual data, over the top of it. And that's still, I'm not quite sure, what's going to happen here. And I love this, right? This was the question from the Jeopardy. A famous red-coiffed clown or just any incompetent fool? Who's bozo? I mean, there was just something hilarious about that Watson could get that. So anyway, one of the points, too, about the Watson is that the training set for that was literally 1,000 years of knowledge, of human knowledge. They consumed every book and journal you can imagine. I don't know if I put it on here or not, something like 240 million pages of information in Watson's brain about knowledge. But see, we don't have that kind of volume of knowledge in healthcare. We just don't. We don't have the kind of knowledge that novels, periodicals, newspapers, and things like that talk to us about bozo, and bozo is a clown, and bozo is an incompetent fool. We don't have that kind of learning set in healthcare. So I'm not sure exactly where it's going to go. I know it's going to go somewhere. One point I might say is that I'm not sure it's going to help much in the wrong diagnosis and wrong treatments. I don't think that's the problem. It's failure to follow what we know is right is a bigger issue. And as the World Health Organization published, more than 50% of all medicines are prescribed, dispensed, or sold inappropriately. 40% of patients in the public sector and 30% are not treated according to clinical guidelines. So it's not like we don't know what to do. So we'll see. I think I should blow through big data, actually, guys. Oh, let me leave one philosophical thought. I always have to leave one philosophical thought. I got nervous when I wrote this headline. I had this Pavlovian response that I was getting ready to take a physics test. But that's not what it is. The three most powerful forces in nature are, and this is my observation in life, it's a mother's faith in her children. I've seen a mother's faith in a child overcome the worst of obstacles in life. Second most important is a father's faith in his children. I've seen that too, although it's not as strong as a mother's. And the third, and this one is one that I try to emphasize, is the leaders and supervisors' faith in those that they lead. And we forget about that. We forget about the impact that we have as leaders and managers, and the impact that we have on people's lives. And I think that's an honor that we probably should respect more. Leaders and supervisors in the workplace have as much, if not more, an impact on the emotional well-being of people as parents do. So I would just encourage all of us in those positions to think about that and treat that with proper reverence. That's it. I think I'm all done. So that's yeah. We don't have time for questions.
Thank you so much. That was
Sure. Thank you, dear. Thank you.
a great way to end the day.
Dale will be here for a couple minutes after.
Thanks, Charles.
Before we end, there's two gentlemen in the wizards in the booth. I'd like them to come out.